Good morning, ladies and gentlemen. I'm Alfredo Colina, and I'm a 12th grade student at Gaithersburg High School, and an intern at the Health and Wellness Center through the Superintendent's Leadership Program. It is a great honor for me to be with you today and have the great opportunity to introduce our keynote speaker, Dr. Benjamin Carson. Dr. Carson had a childhood dream of becoming a physician. Growing up in a single-parent home and being challenged by dire poverty, poor grades, and low self-esteem appeared to preclude the realization of that dream, until his mother, with only a third-grade education, challenged her son to strive for excellence. Dr. Carson is a full professor of neurosurgery, oncology, plastic surgery, and pediatrics at the Johns Hopkins School of Medicine, where he has directed pediatric neurosurgery at the Johns Hopkins Children's Center for over a quarter of a century. His highlights include the first and only successful separation of Siamese twins joined at the back of the head in 1987. Although he has been involved in many newsworthy operations, he feels that each case is noteworthy and deserving of maximum attention. Dr. Carson holds more than 60 honorary doctorate degrees and has received literally hundreds of awards and citations. He sits on the board of directors of numerous organizations, including the Kellogg's Company, Costco Wholesale Corporation, and the Academy of Achievement. In June 2008, he was awarded the Presidential Medal of Freedom, which is the highest civilian honor in the land. Dr. Carson was also recognized that same year by U.S. News and World Report as Harvard and the Harvard Center for Public Leadership as one of America's best leaders. His 5 books, Gifted Hands, Think Big, The Big Picture, Take the Risk, Learning to Identify, Choose and Live with Acceptable Risk, and America the Beautiful, Rediscovering What Made This Nation Great, provide inspiration and insight for leading a successful life. Dr. Carson is president and co-founder of the Carson Scholars Fund, which recognizes young people of all backgrounds for exceptional academic and humanitarian accomplishments. The fund is currently operating in all 50 states and the District of Columbia, having awarded more than $5 million to more than 5,000 scholars. The program also establishes Carson Reading Rooms to encourage young students and their families to discover the pleasure to be found in books and to recognize the true power of learning. As a Carson Scholar, it is a privilege for me to introduce to you the person who has inspired me since I was 12 years old through his life, his achievements, and his leadership to think big and to do my best to fulfill my greatest dream of becoming a cardiovascular surgeon. Ladies and gentlemen, please join me in welcoming Dr. Benjamin Carson.
Thank you. Thank you very much, and thank you for your kind invitation to join you on such an important topic. My day is well into its timeline now. I started earlier than 4 o'clock this morning on my way to the hospital because a baby had fallen out of the bed and had an epidural hematoma. But fortunately, it stabilized, so we didn't have to operate on that baby. But then I had to go to one of the TV stations to do a live interview about the effects of Obamacare and why 55% of physicians don't like it. And then I had to do another interview for national television. And then I had to go back to the hospital and operate on a monkey. Fortunately, they had everything ready when I got there, so as soon as I got through with that, I saw a couple of patients, got in the car, and came here. But there's plenty of other stuff on the other end of the day, so my day is long from being over. But this is such an important topic to discuss, and it reminds me a few years ago I was being interviewed by National Public Radio, and a question was asked. They said, "Dr. Carson, you don't speak about race very often. Why is that?" And I said, "It's because I'm a neurosurgeon." And the questioner looked at me quite quizzically, saying, "What the heck does that have to do with it?" And I said, "You see, when I take someone to the operating room, and I open their scalp and peel it back, and I take off that bone flap and I open the dura, I'm operating on the thing that makes that person who they are." I said, "The cover doesn't make them who they are. It's the brain who makes them who they are." And as you begin to understand that to a greater degree, it gives you a different appreciation of everyone. Having said that, I recognize that most people are not neurosurgeons, and they pay a lot of attention to what's on the outside. And also, the outside has many determinants in terms of, what you think, what you like, how you think you're supposed to think, what you think you're supposed to like. All of those kinds of things come, from cultural issues. But regardless of what one's culture is, what's the most important thing you possess? Obviously, it's your health. That really came to me as an intern at Johns Hopkins, and I would go on the wards, and I would see all these people, CEO of this corporation, the president of this organization, crown prince of this nation, the queen of this place, and dying of some horrible disease. And every single one of them would gladly have given every penny and every title for a clean bill of health. And you begin to realize what you have when you have your health and why it is so vitally important and why we must treasure it above any other possession. You think about Christ. Whenever he went someplace, what did he do? He healed people. That's really what, created the great following, because he healed people. He took care of their most basic and urgent need. So it says a lot. Now, for me, medicine and healing has always been the only thing I ever wanted to do. As a kid, if there was a story on the radio or the television about medicine, I was right there like a magnet. I even like going to the doctor's office. So, it gives you some idea what I was like. And, going to the hospital was like the best thing in the world because, we were medical assistants. And, so sometimes we'd have to wait for quite a while before one of the interns or residents could see us. You know how most people are. You get all huffy. My time is important, too. But I wasn't like that. I was having a good time listening to the PA system. Dr. Jones, to the emergency room, Dr. Johnson, to the clinic. They sounded so important. And I'd be thinking one day they'll be saying, Dr. Carson, Dr. Carson. But, of course, nowadays we have beepers, so I still don't get to hear it. But, but it was that dream sometimes that is the thing that pushes you through when the times get rough. I remember as a first-year medical student how discouraged I was because I did poorly on the first set of comprehensive examinations. And I was sent to see my counselor, who was of a different ethnic persuasion. And he looked at my record. He says, you seem like an intelligent young man. I bet there are a lot of things you could do outside of medicine. And he tried to encourage me to drop out of medical school, said I was just going to torment myself and everybody else. I wasn't cut out for medicine. They could help me get into another discipline. Can you imagine how I felt? I mean, since I was 8 years old, the only thing I ever wanted to do was be a doctor. I finally get to medical school, and the person the university has chosen to help me get through tells me to drop out. I was devastated. I went back to my apartment. I just prayed, and I said, Lord, you got to help me. You got to show me the way here. Am I supposed to drop out? What am I supposed to do? I always thought you wanted me to be a doctor. I don't understand. And then I felt impressed to just do an analysis. Because really, that's why we have these big brains. Say, what kind of courses have you struggled with? What kind of courses have you always done very well with? And I realized that I did very well in courses where I did a lot of reading, and I struggled in courses where I listened to a lot of boring lectures. And there I was listening to 8 hours worth of boring lectures every day, basically wasting 8 hours a day. So I made an executive decision to skip the boring lectures, to spend that time reading, and the rest of medical school was a snap after that. And some years later, when I came back to my medical school as the commencement speaker, I was looking for that counselor because I was going to tell him he's not cut out to be a counselor. Because, some people are just negative. They can always tell you what's wrong. They can never tell you what's right. They can never tell you how to do something. They can tell you why you can't do something. You know, that kind of negativity is not helpful in any circumstance. But the dream got me through all of that and through lots of other things. But, you know, sometimes dreams are not good. And you may remember some summers ago the case of the Bassani Twins, the 29-year-old Iranian women who were joined at the head. Remember, their lifelong dream was to be separated. They scoured the world looking for a team that would be willing to do that. When they first contacted me, I told them about Chang and Ing Bunker, the original Siamese twins, and how they lived to be 63 and never got separated, but they didn't want to hear that. So they finally found a team in Singapore that was willing to take on this enormous risk. And there was no one who thought the risk was less than 50-50 in terms of their living through the operation. But it was a team in Singapore that had done a separation before. It's a team that I had worked with before, actually. So somehow they convinced me to come and join them against my better judgment. And I must say, when I met those young ladies, I was duly impressed. They were full of personality, vivacious, smart. They had learned to speak English in only 7 months, if you can imagine that. They both had college degrees. They both had law degrees. Only one wanted one, but they both had law degrees. So they had a very thorough understanding of the risk that they were undertaking. And they said something to me that really struck me. They said, "Doctor, we would rather die than spend another day stuck together." You know, that seemed harsh to me. But then I did something that I highly recommend. I put myself in their shoes. I said, what would it be like to be stuck to somebody 24/7? Couldn't get away for 1 second. It could be the person you like the most in the world. How long would you like them for? And I began to understand what they were feeling. And that is a critical thing when looking at disparities in healthcare and when looking at diversity issues. Putting yourself in other people's positions. And it sometimes will give you a completely different orientation. You know, I remember when I was an intern at Hopkins, and I would go onto the wards, and almost invariably, I would have my scrubs on, and some nurse would say, Mr. Jones isn't ready to be taken to the OR yet, assuming that I was an orderly. And, you know, I could have gotten angry and exploded and embarrassed them, but I would never do that. I would just say, well, gee, I'm sorry he's not ready. I'm Dr. Carson from the neurosurgery service. And they'd turn about 18 shades of red. And I'd say, you don't need to be embarrassed. It's okay. And I'd be very nice to them. You know, they'd do anything for me after that. So it was good. But, but, you know, the reason that I didn't get angry is because, again, I put myself in their place. From their perspective, the only black men they had ever seen come on that ward with scrubs on were orderlies. So why would they think something different? You know, people tend to react based on their expectations and their experience. All people tend to do that. And, you know, the sooner we understand that, the easier it is to understand a lot of cultural issues. But there's no question that in healthcare there are a lot of disparities. You know, minorities have, you know, much higher incidence of chronic diseases, tend to have less access to primary care, higher death rates from complications of cancer. You know, minority children less likely to be given a prescription for the treatment of their asthma. You know, the list goes on and on and on. And we can spend a lot of time saying, why? But, you know, I like to go further back to more root types of causes. Now, I will tell you, just to gird up your loins, because I am not politically correct, okay? I don't believe in political correctness. I think it's a bunch of garbage myself. Because, you know, it seems to me like a lot of people came to this country from other places trying to escape people who were telling them what they could say and what they could think, and here we come reintroducing it through the back door. And really the emphasis should not be on unanimity of speech and unanimity of thought. The emphasis should be on learning how to be respectful of people with whom you disagree. And it's okay to have disagreements. I always say if two people think the same thing about everything, one of them isn't necessary. You know, you need disagreement, you know, in order to be able to grow, you know? I mean, can you imagine, those of you who are married, if your spouse agreed with you on everything? How boring would that be? You know, you wouldn't like that very much. Sometimes you would, but most of the times I don't think you would like that very much. But, you know, when you embrace different ways of looking at things, there's no question that sometimes it's controversial and sometimes it's uncomfortable. But you just have to accept the fact that that's okay. You know, in my career, I've had a lot of controversy. Still have it even today. It's okay because, you know, I really don't care that much about what other people think. I care about what God thinks. I care a lot about that, and that really is my guiding principle. But, you know, I think back many years ago, the controversy surrounding achondroplasia and their treatment, because achondroplastic dwarfs, as you may know, used to have about a 7% infant mortality rate, sudden infant death. And it was finally concluded that that was probably because they had a very small foramen magnum, the hole in the skull through which the spinal cord and the brainstem meet, and it was squeezing the respiratory centers, and they would die. And then neurosurgeons would try to enlarge the opening, and the morbidity and mortality associated with that was very, very high. So when I went to Rome in 1986 for the first International Human Achondroplasia Conference, and I advocated operating on these patients, the geneticists from around the world were just going nuts. You guys are the ones who kill these patients. What is wrong with you? Don't you learn anything? And they were really quite upset, even though I was advocating a different way of doing it, so that you didn't have to insinuate instruments into that tight area, but actually you would just use a high-speed drill, and you would thin the bone until it was like a potato chip and then just flick it off and never put additional pressure on it. And it was even controversial at Hopkins. But, you know, eventually the controversy just melted away. And now it's standard treatment. But, you know, all things, when you approach them in a new way, in a different way, tend to be a little bit controversial. And, you know, I'm here today to say that, you know, we need to start thinking about some of these disparity and diversity issues perhaps in a little different way, because, you know, you go on the internet and you look up, you know, healthcare disparities, and, you know, you get just tons and tons of stuff going back, you know, 10, 20, 30 years and things talked about. But the problem is things aren't changing that much. That's the problem. So we have to start to ask ourselves, why is that the case? Now, to some degree, you know, disparity in healthcare is baked into the system. You know, I remember in medical school, one of the hospitals that we trained at was Wayne County General. It was the county hospital, you know, just like Cook County Hospital, just like, you know, Baltimore City Hospital used to be like that. Now it's really quite a nice place. But the thing is, in the county hospitals, most of the patients were poor. Most of the patients did not have good insurance. And there was a system in place where those patients were patients of the chief resident and not the patients of the attendings. Now, all the chief residents had access to attendings, but there was a difference. There was the resident service, and there was the attending service. And there would necessarily perhaps be some slight variation in terms of the knowledge and the quality of care, sort of baked into the system. And a lot of people would be outraged, and they would say, no, you can't have that. You can't, that doesn't make any sense. But here's what they forget. Attending physicians are not born attending physicians. They have to become attending physicians. The only way they can become attending physicians is they have to, at some point, be given responsibility for the care of a patient. And the residency training system is the only way that we know how to do that. We still have not figured out quite yet how you can go from 0 to 60 instantly. They have to learn in the process. So the real responsibility is not so much not letting them do things, not letting them make judgments, but just making sure that we have appropriate oversight. I think that's the key, rather than trying to change systems that actually work pretty well. The other thing that I've noticed a lot, particularly in underrepresented minorities, are some significant trust issues. They frequently feel that they're being experimented on, or that people really don't have their best interest in mind. And, I'm called all the time, even today in 2012 at Johns Hopkins by colleagues in various departments who just say, could you just speak to this family? They don't seem to trust us, but they would trust you, even though they don't know me. But, and I do, and I go and talk to them and try to calm their fears. But one of the reasons a lot of times that patients don't trust people is because they don't spend time with them. They don't sit on the bed and touch their hand and find out who they are and what their concerns are, and then start probing them about their disease. It makes a huge difference when you actually care about the person, you know about them. When the next time you see them, you can say, well, how's your 8-year-old daughter doing? And that they know that you actually remember that about them. And the other horrible thing that some people do is they say, I can't help you. You have a problem that's, it's not within my sphere of expertise. Sorry. And they leave. That's a horrible thing to do. I see people all the time who may have a problem that really is not a neurosurgical problem, but they still have a problem. And you still have a lot more expertise in how to get that problem solved than they do. So is there anything wrong with helping them and guiding them, to the right person, to the right facilities? It makes all the difference in the world for them. And that's the kind of thing I think that really builds into the caring relationship and the trusting relationship. But the other problem, and I'm sure everyone in this room is very aware of this, is patients from low socioeconomic status have a disproportionately high number of medical lawsuits. And as a result of that, some medical practitioners tend to be somewhat weary of them. But, the problem is that kind of feeds on itself, because if you're weary of them because you think they're likely to bring a lawsuit, that changes the relationship. Whereas if you really get to know them and that trusting relationship is built up, that lawsuit tends to be considerably less likely to come. Now, do bear in mind that there is a significant problem with medical malpractice in this country. Much bigger problem here than it is virtually anywhere else. I lived in Australia for a year, and my malpractice premiums for the year were $200. Not $200,000. $200. You know, in Philadelphia today, malpractice premium for a neurosurgeon in private practice who's got a pristine record, never had a case against them, $300,000. Chicago, $380,000. It's absolutely absurd. And the worst thing about it is it tends to make people practice defensive medicine instead of practicing medicine the way it's supposed to be done. Now, some people have tried to say, it's not that big a deal. It's only a few $1 billion here and there. But, you know, the fact of the matter is it's much more than that. And virtually everybody, whether they admit it or not, is always cognizant of it. And they order extra tests. They do extra things to cover themselves. And this adds enormously to the cost. And it is a huge problem that we have to deal with. You know, neurosurgeons are some of the most frequently sued people, neurosurgeons and obstetricians. And the problem is, you know, the lawyers, the ambulance-chasing lawyers, you know, they don't really care whether the case has any merit or not. It doesn't matter, because all they got to do is get a case. And, you know, the doctor and the hospital don't want to spend 6 months litigating something. You know, that's not cost-effective for them. So they just keep dropping the settlement price until they reach the sweet point. Case is settled. They get their 30 to 40% and move on to the next case. And the problem is there's no consequences for doing that. There's no consequences for the patient. You know, you got nothing to lose, and you may become a millionaire. So obviously, when we're talking about the whole disparity issue, we have to go back and deal with those kinds of issues too. That's what I mean when I say, you know, we're talking about some things, looking at it from a little different point of view, and looking at some of the things that really create some of the divisions that occur in our society. And it is eminently possible to get this problem under control. It's just that the Trial Lawyers Association is a very powerful lobbying group, and they fight tooth and nail everything that comes up that would solve the problem, because they don't want the problem solved, because it's a very lucrative entree for them. Well, I have found, you know, in terms of the disparities in healthcare, it is largely financial. Now, I know that there are some studies that have been done that have shown that, you know, African Americans who are affluent and the ones who are poor both suffer from issues in disparate care. I'm not sure that I'm really buying that, because what I've been practicing medicine now for 36 years, and I have seen with my own eyes very specifically in many places that people who are well educated and who are well financed are treated differently than people who are not. And some people will sit there, no, it's not true. But it is true, whether you admit it or not. And it's not just in medicine, it's in everything. You know, read the second chapter of the book of James, where he says, you know, why do you take this guy who comes in with gold and raiment, you give him the good seat, and the beggar, you want him to sit under the bench, you know? It's a human tendency, and it's a human tendency that has to be rejected. We have to teach people to reject that early on in their careers. You know, Jesus Christ died for everybody. He didn't just die for rich people. So, we really need to begin to emphasize that as soon as a person enters the medical profession, as soon as they enter the nursing profession, any of the allied professions, everybody has tremendous worth. Everybody's life is worth the maximum effort. And, I think back to my own health issues more than 10 years ago now. I was one of those people who got an annual physical exam, got my blood pressure checked, I got everything checked. There was no little section that says deferred. I got everything done. I had my PSAs done, and everything was okay. But I started noticing that all of a sudden, when I was operating, I was looking at the clock. Because I used to be able to operate for 10, 12, 15 hours without a bathroom break, but all of a sudden I couldn't do that anymore. And I said, something's wrong. And I went and talked to Pat Walsh, the chief of urology at Hopkins, who's a good friend, and I said, Pat, what do you think about this? He said, you probably got a little prostatitis. Let's try a little antibiotics. But that didn't work. He said, well, maybe you got a little focal hypertrophy, maybe a little Flomax. That didn't work. He said, well, I know you had a PSA done and it was okay, but let's just check it again. It was ever so slightly elevated. He said, you should have a prostate biopsy. Now, if anybody ever told you a prostate biopsy doesn't hurt, it doesn't hurt them. So they left that one word out. So, after about the sixth biopsy, I'm saying, you know what, cancer's not that bad. We can stop. But then I said, he said, it's very unlikely that you have cancer. Maybe an 18% chance. I said, nevertheless, as soon as you know something, let me know. The next day, I'm operating. The phone rings. The nurse puts the phone up to my ear, and I get the news, not only do you have cancer, but you have a very aggressive form. And, I had to put that out of my mind and finish the operation. And as I'm traveling home, I'm just thinking, there's got to be some mistake. But then I had to have an MRI done to see whether it had metastasized. And when I came out of the MRI, I was expecting one of the radiologists to say, hey, Ben, your scan looks great, no problems. But there was no one there to say that. And the technician gave me my films. And I went up to my office and put them on the board, and my heart sank as I saw all these lesions up and down my spine. And I checked to see if it was my name, but it was. And then I just sat down at my desk and I started thinking how fortunate I had been. I was 50 years old. And, when I was a kid growing up in Detroit and Boston, seeing all the carnage, both of my favorite older cousins were killed. I never expected to live to be beyond 25. And there I was twice that old. And I said, it's been a good life. And it's okay. And then my senior PA came in and she said, what it show? She's been with me my entire career. And she said, I knew it wasn't going to show anything. And then she went over and looked at it and came back with the longest face imaginable. But a funny thing happened. The next day, they were announcing on the radio that I had a glioblastoma, a malignant brain tumor. And then I had lung cancer, liver cancer, bone cancer, skin cancer, you name it, I had it. I was dying. I had died already. One lady called my office and she said, I heard Dr. Carson was dead. I want to speak to him. But it was pretty amazing. But I must say there was such an outpouring. I really never had an idea of how much I meant to so many people. I had more than 10 duffel bags of cards and letters from janitors to the President and Mrs. Bush saying that they were praying for me. And I was getting all kinds of things in the mail and special delivery pills and potions, and grasses and herbs. I mean, it was unbelievable. And but a lot of literature also, which I read. But I think the Lord just got tired of hearing about me, because it turned out that the lesions on my spine were a congenital anomaly of the bone marrow, perfectly benign, not metastasis at all. So I was able to have surgery by Dr. Walsh, who invented the nerve-sparing prostatectomy, and today I'm cancer-free. So it all worked out well. But I would quickly add, when the surgery was done, the cancer was less than 1 millimeter from breaking through the capsule. And the fact that I had access to the very best care probably is the reason that I'm standing here before you today. And it makes a huge, huge difference. So the issue that we really have to start talking about is access. And how do we create that kind of access? You see, we in this country spend more than twice as much per capita on health care as the next closest nation in the world. And yet we have these horrendous access problems. So it's not because we don't care, and it's not because we don't spend enough money. And this is where I think we're going to have to start putting our energies. And, primary care is one of the places where there's an enormous difference made, because you begin to look at things before they become problematic when you're seeing it on a regular basis. But so many people, particularly in the minority community, do not have access to good primary care. Even people who are not in the minority community, who have good insurance, are having trouble finding a primary care specialist because they're booked, for months. And some of you probably saw the survey a few weeks ago where, 45% of primary care physicians are highly dissatisfied with their careers. Why? Because from morning to evening, every 15 minutes, got to crank a patient through. This is not what they were trained to do. This is not what their Oslerian skills were honed to do. And it becomes a very, very unpleasant situation. And we can't just ignore it. Part of the problem is that we don't have enough primary care providers. And until we solve that problem, the access problem will continue to be horrible for minorities. It'll be horrible for everybody, but it'll be more horrible, particularly for people who don't have good insurance, who don't have money. Because, one of the solutions that the primary care physicians have adopted is concierge services, where, a practitioner will say, I'm just going to have 300 patients a year. And they'll keep that 300 patient slot full, and each patient pays $5,000 a year, and all of their care is taken care of. They have the phone number of their primary care physician. They don't have to wait. Things are taken care of. There are a lot of people who have $3,000, $4,000, $5,000 who can do that. So they're not really affected by this. But there are a lot of people who don't have that kind of money. So what we really need to be asking ourselves is, what can we learn from that? And is there some kind of way we can model this thing to make it work that way, so that all people can have access to that kind of thing? This is, I think, the kind of thing that we have to be thinking about if we're ever going to solve this problem. This primary care problem is actually scheduled to get much worse, because we're going to dump another 30 million people into the system, on Medicare. and Medicaid. And then on top of that, we're going to decrease the reimbursements to the hospitals and the practitioners. So even fewer people will be willing to take these patients. There'll be even more concierge services. So long, long lines for people just to get the kind of care they need. So if anybody thinks that we've solved this problem, I got news for you. We have not solved this problem. And it's one of the reasons that I think each of us who are involved in some way with healthcare have to begin to use our collective experience and our knowledge to come up with real solutions that really work. You know, whether Obamacare remains or whether it gets overturned doesn't matter. What matters is that we have to come up with stuff that works. And it's really up to us, the very people who are involved in this, to do it. It's not up to the politicians. And, you know, I have many friends who are politicians. I love them. They're good people. But they don't know anything about healthcare. You know, I'm sorry. You know, it's sort of like if you have an airplane that's, you know, not doing well, you need to get an airplane mechanic, not somebody who flies on the airplane, you know, to fix it. So with all due respect to the politicians, and we need them in various ways, but where we need them primarily is to listen to the things that need to be done. And I think about, you know, our system right now. You know, why is it so expensive? Why do we spend so much money? Well, if you want to get an appendectomy in Dallas versus Washington, D.C., versus Baltimore versus New York, you know, versus Kansas City, different cost, different ways of submitting bills, different ways of collecting, all of which justifies the mountains and mountains of paperwork and the armies of people to push them around, all of which has to be paid out of the healthcare dollar. Not even necessary, because every single diagnosis has something known as the ICD-9 code, and every single procedure has something known as the CPT code, and we have computers, which means all billing and collection can be done virtually instantly at very little cost. Now, the insurance companies don't like that idea. And they say, well, if it was that easy, then some practitioner would just say, I did 2 appendectomies and get paid twice, and go and buy a nice Mercedes and go away. Problem. You know, just very few medical practitioners would do that. I mean, there were some who would. I grant you that. But the solution to that is not a gigantic bureaucracy. The solution to that is what I call the Saudi Arabian solution. Why don't people steal in Saudi Arabia? Because you cut off their digits. Now, I wouldn't cut off their digits, but I would put some real teeth into the penalties. I mean, you would lose your medical license for life. You would go to jail for no less than 10 years, and you would lose all your personal assets. You think anybody would even think about medical fraud in that situation? Not only would they not think about it, they would check every bill 7 ways to Sunday to make sure it was right. They would have all kind of safeguards in place. It would not happen. Save us enormous amount of money. What about the 50 million people who have no health care insurance? Well, first of all, they don't exist because they can go to the emergency room. And by law, if they have an emergency, they have to be taken care of. But here's the problem. It costs 5 times more to take care of them in an emergency room than it does in the local clinic. Guess who gets to pay that 5 times more? All of us. Okay? These are the reasons that we have these high prices. So, what do we do about that? Well, we simply say to ourselves, how do we get these people to go to the clinic? Is there something that we can do to encourage these people to go to the clinic? And there's a nice model for this, the food stamp model. Why don't people starve to death in our country? Because they get food stamps. And guess what? They learn very quickly how to use those food stamps. They don't go out the first 5 days and buy porterhouse steak and starve the rest of the month. And by the same token, if we had a system where people had their own electronic medical account that maybe was replenished each month, then when Mr. Smith gets that diabetic foot ulcer, you think he's going to go to the emergency room and blow half of it? No. He's going to go to the clinic. He gets the same treatment in both places, but the difference is in the emergency room, they patch him up and send him out. In the clinic, they patch him up and say, Mr. Smith, let's get your diabetes under control, so you're not back here in 3 weeks. And that preventive aspect and that personal care and that relationship begins to develop. These are things we can do. You know, I personally have been advocating recently that when anybody is born in this country, they get a birth certificate, an electronic medical record, and a health savings account. They get those 3 things. The health savings account can be contributed to from the day they are born with pre-tax dollars. And for those people who are indigent, for which we are setting aside money anyway, it goes into their health savings account. Whether they use it or not, it goes in there. Guess what? Over the course of a period of time, it builds up. They begin to have some autonomy and personal responsibility for their own lives. They begin to develop a relationship with the healthcare provider. They're able to accumulate enough money to buy bridge insurance so that gap insurance can be purchased. But this is all under their own control. Now, if you come to me and you have a problem and I say, let's do a CAT scan, and that's coming out of your HSA, you're saying, doctor, do we really need that CAT scan? And then if I say 2 weeks later, let's do another CAT scan, you say, do we really need that CAT scan? You know, but I'm not going to say that to you probably if I know it's coming out of your HSA anyway. I'm going to be looking at other ways to do things. If we couple that with tort reform, can you imagine the impact that that would have on cost? So, you know, these are the kinds of things that will help take care of the disparities that we see. Now, I'm going to say something here that's going to be very controversial and that's going to offend some people. So I tell you right now, that's the case. Poverty is one of the major reasons for the disparities. One of the major causes of poverty is out of wedlock births. In the African-American community, 72% of the babies are being born out of wedlock. We are not doing people any favors by not talking about this and by acting like it's okay and by acting like politically correct to just say that every lifestyle is okay. It's not good. Furthermore, with African-American males, you know, I speak at a lot of graduations all across the country. And one of the things that always hurts my heart is I don't see a whole lot of black males graduating. There are more black males in the penal system than there are in higher education. This is not a good situation. Anybody who's in the educational arena knows that young black males are good students, kindergarten, first grade, second grade, just like anybody else. As they start to get into the older grades, something begins to happen. You know, that peer pressure begins to kick in. They want to be cool. And then, you know, they get about 5th grade, they start reading about this great nation of ours. And it is a great nation. But they notice that there's nobody who looks like them who really did that much. Everybody wants to know, what did my ancestors do? They say, well, maybe next year when I take world history. But next year they take world history, the same thing happens. What did my ancestors do? Where do I fit in? And then they go home and turn television on. Oh, there we are, playing basketball, baseball, football, rapping in some baggy pants, acting a fool on some sitcom. You begin to get a very different impression of what success for you means. Doesn't mean being the CEO of a Fortune 500 company or a nuclear physicist. And by the time they figure out that they're not going to be the next Michael Jordan or the next Puffy Daddy, it's too late. It's too late. And now, up drives this big black BMW with tinted glass out. That's this tall guy with furs and jewels and women. You want to be like me? I can show you how to get all this stuff. Plus, that society sold you a bill of goods. Next thing you know, you're looking at television, and you see this young man being led away in handcuffs, trying to shield his face from the camera. You say, that looks like little Johnny. What happened? He was such a good boy. Well, what happens to little Johnnies across this country hundreds of times every day. And it never had to happen. Because anybody could have taken little Johnny when he was 6 years old and walked down the streets of Washington, D.C., and given him a black history lesson he would have never forgotten. They could have started by pointing to his shoes and say, it was Jan Matzliger, a black man who invented the automatic shoe lasting machine, which revolutionized the shoe industry throughout the world. You step on that clean street, you tell them it was Charles Brooks, a black man who invented the street sweeper, those machines with the big brushes. And down that street comes one of those big refrigerated tractor-trailer trucks. You tell them it was Frederick Jones, a black man who invented the refrigeration system for trucks. And it comes to a stop at the red light, and you tell them it was Garrett Morgan, a black man who invented the traffic signal. And while you're talking about him, how he invented the gas mask that saved lots of lives during the war. And while you're talking about the war, Henrietta Bradbury, a black woman who invented the underwater cannon, made it possible to launch torpedoes from submarines. And then you'll see a beautiful black woman walking down the street. A black man did not invent her, but you can use that opportunity to talk about Madam C.J. Walker, a black woman who invented cosmetic products for women of dark complexion, was the first woman of any nationality in America to become a millionaire on her own efforts. And you walk past the hospital and you talk about Charles Drew and his contributions to blood banking and the understanding of blood plasma. Daniel Hell Williams, the first successful open heart surgery in the world, had an operative mortality rate less than 1.5%. You look up at that surgical light, Thomas Edison. You didn't know he was black, did you? Well, actually, he wasn't. But his right-hand man, Lewis Latimer, was. And you can tell how Lewis Latimer came up with the filament that made the light bulb work for more than 2 or 3 days, how he invented the electric lamp, did pioneering work, incandescent and fluorescent light, diagrammed the telephone for Alexander Graham Bell, was a tremendous inventor in his own right. Most people have never even heard of him. You walk past the railroad tracks. Andrew Beard, the automatic railroad car coupler, spurred on the Industrial Revolution. Elijah McCoy, the automatic lubrication system for locomotive engines. In fact, Elijah McCoy had so many great inventions that when something new would come out, people would say, is that a McCoy? Is that the real McCoy? You got racist people like David Duke talking about the real McCoy, don't even know who they're talking about. But you can see, that young man has no reason to believe that his ancestors didn't play a very important role in developing this country. He should feel fully invested in it. He should feel in every way an important part of this nation, because sometimes people don't feel that they are important enough. And therefore, they don't think you should be wasting your time on them. We have to disabuse people of that notion. We have to get them to know that we value every single one of them. And remember, for every one of those young people that we can keep from going down that path of self-destruction, it's one less person we have to be afraid of. One less person we have to protect our families from. One less person we have to pay for in the penal system or the welfare system. One more tax-paying, productive member of society who may discover a new energy source or the cure for cancer. We can't afford to throw any of them away. We need every single one of them. And we need to begin to help all of our people understand how incredibly valuable they are. Those are the kinds of things that will bring about the closure of this disparity gap. And I have several other things to say, but I'm not going to say them because I've run out of time. But I just want to end with one thing here, and that is determination. Determination. See, some people think that we have solved this issue with Obamacare. We haven't solved the problem. We have got to be determined. We're going to run into all kinds of problems as things are implemented. We can't throw up our hands in disgust. We have to work together. You know, if you're a Republican, I want you to make a pledge that you're going to be nice to a Democrat. If you're a Democrat, I want you to be nice to a Republican, because we got to get over all this stuff. We have much more in common than we have apart. You know, that doesn't make any sense. But this is 2012, a great year to talk about determination because it's 200 years after the War of 1812. And think about that, what was going on there. You know, the British had decided that these young whippersnapper Americans did not deserve to be independent. And they were winning that war as they marched up the eastern seaboard, destroying city after city. They burned down Washington, D.C., burned down the White House. Next stop, Fort McHenry in the Chesapeake Bay. And as that armada of ships rolled in, battleships as far as you could see, it was looking very bleak. General Armistead, the commander of Fort McHenry, had a large American flag constructed to fly over the fort. The British commander was incensed. "Take that flag down," he said. "We are in control here. You have until dusk to take that flag down. If you don't take it down, we will start a bombardment. We will reduce you to ashes. We will continue the fire until you take that flag down." There was a young amateur American poet on board by the name of Francis Scott Key. He was on a mission from President Madison to try to gain the release of an American physician who was being held captive. He overheard the British plan, so they were not going to let him off the ship. And his heart was heavy as the sun sank that evening, and he thought about his beloved fledgling nation, once again about to become a colony. And as that bombardment started that night, bombs bursting in air, missiles all night long, it looked like the 4th of July. There was so much fireworks. And he strained his eyes, trying to see if the fort was there, if the flag was there. He couldn't see all the dust and the debris. And at the crack of dawn, he was right out there at the banister looking. But he couldn't see because there was so much debris in the air. But finally, there was a clearing in the debris. And he saw the most beautiful thing he'd ever seen in his life. It was the torn and tattered stars and stripes still waving. And many historians say that was the beginning of the turning of the tide of War of 1812. And if you'd gone onto the grounds of Fort McHenry that day, at the base of that flag, you would have seen the bodies of American soldiers who took turns holding that flag up. You want to talk about determination? You see, that's what this country is all about. We're not about division. We're not about giving up. This is our responsibility. Healthcare It's our responsibility. And the sooner we recognize that, the sooner we have one nation under God, indivisible, with liberty and justice for all. Thank you very much.